Mallory-Weiss is something completely different. And we do pancreatitis a different day. So, what are we thinking? Okay, we're worried about hemorrhage. Okay. So there's peptic ulcers. It's fine if it's a little tiny ulcer. You know, people take something for that. But if that ulcer starts to grow and then it gets H. pylori in it, and then it starts to rupture, and then it's going to start bleeding. It's going to start bleeding. And stomach acid is not going to help out with that peptic ulcer disease. Well, A and C is for lower GI leads, right? Where's the blood coming from? It's in your abdominis, likely upper GI. We don't do barium. Specifically said that. Laparoscopy is not going to help out. But you can cameras in her belly. So, choose stuff. Endoscopy. That's good, and that's just a general term. Somebody gets that to go evaluate for malignancies or esophagitis, then that's going to be an EGD. Okay, and if it's going to be for screening purposes for malignancy, polyps, any other diverticulitis, scope would be colonoscopy for the opposite side. Not on warfarin. Propranolol. It's an anti-anxiety / blood pressure medication. That's not going to help. Calcium's not going to help. Cimetidine, it is for reflux. So, I told you somebody that is a cirrhotic alcoholic is immunocompromised. They need antibiotics. Fluoroquinolones. So fluoroquinolones or ceftriaxone, either of that's out of all those choices, that is the correct one. So I'm asking specifically which ones reduces hospital stays and the need for surgery. That was on the slide. It's going to be your PPI. That tranexamic acid, unfortunately, has not been proven. Metadine, we don't. Do we give that out anymore? What's the trade name for that? It's Zantac. It's black box now. They didn't talcum powder cause cancer. Crazy, but whatever. Took that crap for years. The only safe one is going to be from octreotide if that patient had been a cirrhotic, like I said, non-interstitial bleeding. We can talk about fasting symptoms, barium swallows, we can talk about CT injecting, whatever. Now, she means the upper endoscopy, diagnostic, and therapy. We need to confirm it. We need to confirm it. So, my apologies again, there's just no great videos out there of diverticulitis. Very, very common, It's a first world problem. First world problem. 3 pages to get through all these objectives. 3 pages. Again, first world disease, right here. Increasingly prevalent in industrialized nations. Much more of a why? Why do we have that problem? Because we don't eat enough fiber. We eat a lot of processed food, McDonald's, Burger King. Red meat definitely increases diverticulitis. And then just the fact that more obese people are. I'm talking about you guys, but I'm in the military. It's looking pretty good in here. And less activity. Sedentary lifestyle increases diverticulitis. So this is kind of an inevitable type of thing, especially first world. Less than 5% of the age of 40. If they're under the age of 40 and they have diverticulitis, it's probably going to be pretty severe. So earlier, but the point is, if you make it to 85, greater than 70% of people have it. So Usually incidental finding most of the time. I find this, it's just doing CT scan to draw some abdominal pain, and they have a little bit of diverticular disease. That's what we end up treating. Very simple to treat as long as it is not complicated. Usually pretty benign. A little pathophys for you. So small herniations where the base of recta or the vasculature penetrates the colonic wall. It's weak in that spot. So it has a tendency to cause little outpouchings where the blood supply is. If it's true, it involves all 4 layers there. All 4 layers. Meaning the mucosa, submucosa, muscularis externa, and the serosa. False if it only involves the 2 inner layers. A lot of bad bacteria are associated with this, which is why these can be pretty horrible. Bacteroides, peppered streptococcus, Clostridium, Fusobacterium, gram-negative rods, which is pretty much E. coli all day long. This is why most old people with urinary tract infections are E. coli. It's just poor hygiene, unfortunately. Pretty visual, folks. Should give you an idea of how that happens. It's diverticulosis on your left, diverticulitis on your right. So those get inflamed, and then they lead to bleeding, which makes it the most common cause of lower GI bleeds. Not rectal bleeds. It's a combination. Bacteria starts to grow, infection starts, ischemia develops as that swelling happens, and it causes erosion in those little pockets that cause the micro perforations and bleed. So, a lot of things that happen with this is these pressures get off because people have altered bowel motility. Not enough fiber, basically not going to the bathroom enough. Or it's just kind of stopped up. That causes increased intraluminal colonic pressures, causes diverticulitis to formality. And you have smoking, obesity playing a role. They say active lifestyle has been proven. I think that's, I don't know, people go for a ride and maybe they feel like they have to go to the bathroom afterwards. All these other things cause you risk for that. NSAIDs, steroids, obviously. NSAIDs because it's going to cause small perforations even to the bowel. Steroids because it kind of causes atrophy and things to thin out. Opioids because they cause the bowel to slow down. If you ever discharge somebody with an opioid, consider sending them out with some type of stool softener. Now I think that Dagazade is not so great, but it's better than nothing. For the most part, I tell them to drink lots of water, because that's just a side effect of narcotics to slow the bowel down. So diverticulitis, most exclusively left side. I told you if it's right sided, it's worse. But most left sided, descending colon, and the sigmoid as well. Pretty simple here. Left lower abdominal pain. Now do we have to differentiate to make sure, especially that that's not radiating down to the testicle, it's not a hernia. Make sure if it is below the umbilicus in a female, then we need to consider doing a pelvic exam. We need to consider doing a genital exam in a male. Definitely food for thought, but left lower acquired abdominal pain. So fever, and a lot of times these people do have leukocytosis. So pain can come and go. And what level is leukocytosis? Above what? 12,000? There we go. So they can have diarrhea, they can have constipation, it can kind of come to what's going to be a little bit different for everybody. So hang your hat on that. Kind of nausea, vomiting, be anorexic, very similar to appendicitis, but this is going to be left side. Sometimes urinary symptoms, and that just has to do with sterile pyuria. So if you do a urine, it can have white blood cells in it, but it'll be a sterile pyuria. What does that mean? If you send the urine off for a culture, the culture is going to come back negative, even though it looks like all day long that there's a urinary tract infection. That's sterile pyuria that has to do with the inflammation from the sigmoid colon being so close to the bladder. So just be aware that you can have a sterile pyuria. Don't just throw it up as like, oh, it's probably just a urinary tract infection. Probably not. Sometimes you can feel a mass there. I've never palpated one, but and just be aware if you're getting rebound, tenderness, guarding, then we're probably in the realm of some pretty significant parietal pain, peritoneal irritation, and we need to be concerned that potentially we have an abscess or a rupture if we're having that much problems. So, Really helpful if somebody comes in, yeah, I just have my normal diverticulitis flare up and it's not doing too bad, I just want to get checked out. So, for a lot of those folks, I'm not necessarily in this realm, but technology says, okay, I have normal diverticulitis, you look good, you don't need to do anything, here's your antibiotics, go home. But if it's anything different from that, you need to work it out. For me personally, I'm going to work it up regardless, I want to know for sure. I can't say, I can't use my x-ray vision or my CT vision to determine whether or not there's not a rupture or an abscess, so I'm going to give a full Monty. I'm going to give a full Monty. So I also want to make sure that it's not something else that I'm missing. So, what other things there? It could be a gynecological emergency, it could be cancer, it could be an inflammatory bowel disease, Crohn's, ulcerative colitis, or an infectious colitis. So, I feel better once I withdraw my vitals, I got my physical exam, I got my labs, deciding whether or not I want to do imaging. Because why? Because there's all the possible things it could be. Again, I don't show you this because I'm going to test you on it. I show you this because you need to be thinking, be out here. Maybe here, but somewhere. It's like having a kiddo come in that's not vaccinated. Your differential just went from like right here to out here. So that's what. Vaccinate your kid and measles. Awesome. So don't forget that as you push on that left side, if you get rebound tendons, that could be a rosing sign, that could be appendicitis. But this is 21 different diagnoses that should be somewhere in there. Laboratory data, usually not super helpful, other than I would say that it is helpful if you have a little bit of white count and you have something that's going on. Now everybody needs to figure out their own threshold for what a white count is concerning. I mean, anything above 12,000 is considered leukocytosis, but I think 15 is about my cutoff because anything between 12 and 15 can be steroid to marginalized stress to pregnancy to other types of things. So, but want to make sure I rule it out any infection. Also make sure there's no anemia with this. Maybe they haven't noticed it. And now you get that CBC back and you're like, oh crap, man, you should make sure it's throat. Renal panel, again, making sure that their kidneys can handle that CT. And then BUN, because this is an upper GI bleed. And then I always get a UA because I want to say, man, it's left lower quadrant pain, but maybe they're passing this down. Maybe they're passing this down. So, what do they want with that? They want a contrasted abdominal pelvis CT. And because they want it contrasted, that's exactly one of the big reasons why we get that BMP. We need to make sure that kidneys can handle that. GFR and creatinine are not in the toilet. Otherwise, we can't. We may not be able to do that, or we may have to give them fluids, or we may have to go for a non-con and not get all the information we want. Some people, some protocols do prefer that they do oral contrast with this. That's going to be up here in TF. But if the CT says no diverticulitis, that is pretty much 100%. Pretty much 100% sensitivity, so very useful. Remember, CT without any contrast. Compression ultrasound has been explored. Not great, very operator dependent. It's very good at that. Not a lot of people. I don't spend a lot of time looking at bowel. Very difficult, especially as it has its little peristalsis, makes it very difficult to find. Plus the amount of bowel gas, very difficult. Even if somebody's experienced, I've seen like maybe above 80% of them do that. So CT also, because I want to make sure that that did not perf. Now that does not have an abscess. That's really my concern. Really, really my concern. So if it's uncomplicated, so that has no signs of actual infection, and that's what phlegmon is. Phlegmon is an early abscess versus complication. And that can be any number of these things. Where it's causing obstructive fistula, perforation, abscess. Be concerned about that. Got that cool little chart here. What I like about this, you see about.
So the previous slide, are you still using the contrast for that last one?
For what?
For perforation versus abscess, are you still using the contrast?
Yeah, absolutely, absolutely. Contrast can be what you go for all the time with diverticulitis. You're really concerned. But again, if you're worried about perforation, abscess, and you're going to have some more pretty significant abdominal exam. You should find some much more peritoneal signs, a lot more pain, a lot more tenderness, potentially fevers, leukocytosis, then we're like, man, this is bad. This is bad. So uncomplicated, and then you just realize that the majority of these people do pretty well. If they're well appearing, you go down that left side of the chart there, and 90% success rate. Now we do want to do an outpatient colonoscopy at 6 weeks. We just follow that chart. Again, for your visual learners, we have about a 5% failure rate and go there. If somebody fails that, meaning they go home on oral antibiotics and they don't get better, they come back in, that's like hands down needs to be the issue. Hands down needs to be the issue. So, again, complicated. Make sure they're NPO. If you're going to start antibiotics, you're usually going to do cultures all the time with that. If you're starting antibiotics on somebody IV in the emergency department, you should always consider doing cultures. That's just good diligence for that inpatient team. I can't tell you how many people will come back with like a positive MRSA or something like that, and then they need to switch up antibiotics. It just helps out that team later. Plus, if they go and do all the mic, right into where mic testing mean inhibitory concentration, it's where they do biograms and they figure out what's susceptible and what's resistant. It can be very important. It's like, oh, I've been using this antibiotic, I didn't do anything. So, uncomplicated diverticulitis, bowel rest, so we tell a liquid diet. We don't really want you eating anything. So that's gonna be like shakes, protein shakes, that kind of thing. Oral antibiotics. So there's been no advantage in uncomplicated diverticulitis between IV and oral. So you don't need to worry about giving them a dose or bringing them into the hospital. Majority of these people do just fine. Majority of these people do fine. There's this growing interest with not giving antibiotics at all, but that's because there's people out there that are worried that it's causing allergies, nausea, vomiting, and the concern for C. diff for being on antibiotics. Yeah, that's always potential, it's always a possibility, but you can't get every single person. Complicated though, that comes in. It's complicated diverticulitis, and that CT scan should tell you, or you can't get that person's pain under control, or they're not PO tolerant, or they're starting to show signs of sepsis and you get them admitted. So that's IV antibiotics. They're going to bring them in, and then they use this Hinchy classification scheme. Hinchy classification scheme. I just need you to be aware of the fact that what is likely going to get admitted. If they're anywhere in this realm, it's likely going to be admitted. So, most common complications, abscess, and like Mom just said, early abscess. Abscess. So, percutaneous drainage. Percutaneous drainage is how they would handle a lot of these. So, there's under 3 centimeters, it doesn't require anything other than IV antibiotics. Under 3 centimeters just comes in IV antibiotics, it's not need any drainage. Anything bigger than 3 centimeters is going to need percutaneous drainage. And then we always worry about if that perfs. If you have perforation there, they're going to need to open up the belly. Because what was in that bowel? Okay, FOS. And that's somewhere where it does not need to be, and that's full of bacteria. So uncomplicated diverticulitis, hopefully follow up in 2-3 days with their primary care. Good luck. Good luck with that. If they can't, and I tell people if you can't get in to see your primary care in 2 to 3 days, which is what's recommended, then you come back to the first clinic. Say, hey, I'm just here to get rechecked. You're going to go in, you check them, no problem. Make sure vital signs are stable, non-toxic, which is what I love to put in my medical decision making. The patient was non-toxic. I love that. So make sure that they're handling their analgesia or their pain, not have any significant red flags from physical exam findings, and then clear diet and oral antibiotics that they're tolerating all that. Any number of reasons to admit patients. So I'm not going to send somebody home that can't get their vomiting under control. They're not PO tolerant. I'm not sending somebody home that has a crap load of comorbid conditions. Lack of support. That white count sign up front, I'm like, that's not going on. And I can get your fever under control, you're old, especially if you're immunocompromised. And then again, if I can't keep your pain under control. Pretty simple. Everybody kind of has their thresholds of what they consider elderly. There's there's no other thresholds with what they consider leukocytosis. That's for you to figure out in phase 2 where your line in the sand is with what goes home and what doesn't. Stick to your guns. So, obviously immunocompromised. I find every reason to get that person admitted. Like I'm gonna make a decision to admit somebody, and I just have to figure out exactly why. Even if it comes down to a social admit because of lack of support. Chronic steroids, and then anybody fails outpatient, you can bring them back in and need to be likely admitted for IV antibiotics. So continued symptoms or worsening imaging within 6 weeks is what classifies as a failed outcome. So again, people under the age of 40 should not have this diverticulitis, so it's very concerning. More virulent unless you get it later. So we worry about these folks. You have somebody under the age of 40 under diverticulitis, you need to consider getting that person admitted because they just have all these other risks associated with that, requiring surgery. It's complicated, meaning abscesses, and then recurrence, just worse. So beware of those bounce back, especially in younger folks. Here's that Meckel's diverticulum, rule 2. So you may see this potential on the pants. So 2% population, 2 feet from the ileocecal valve, which is going to be down near the terminal ileum, and then symptomatic in 2% of patients. So crampy abdominal pain, sometimes nausea, vomiting, bleeding. So that is also known as radionuclide or nuclear imaging. I don't recommend CT. That is typically going to tag red blood cells. Treatment is surgical. It's going to be a pediatric surgeon that will take care of that. So again, it's more of a kiddo pediatric disease. Versus, I didn't know what this was at one point. And I'm getting these CTs back, and all it says is epiploic appendages. I'm like, what the heck is that? These are just small fluid-filled sacs that are within the peritoneum, and what happens is they basically torse. When a person's an active person, they torse over, cut off blood flow, cause a torsion, venous thrombosis. Can be very painful, can cause nausea, vomiting. Very mixed up with a bunch of other types of symptoms because they're usually very diffuse abdominal pain. What do? We just treat it. Try and treat their pain. Usually goes away within a week. That just torse. Eventually blood supply cuts off, gets ischemic, and just dies, and no big deal. But this is on here because I've seen it a lot, and I didn't know what it was years ago. A while ago. So, make sure if you are sending these people out to woods, we need to make sure to send some sort of stool softener, ensuring that they drink plenty of water. All right. We're more than halfway through, folks, so should have no problem getting towards the end. My goal is to not have to use all the time. Am I going too fast? Okay, just making sure. All right. We agree, and so we're going to do it with contrast, right? Do the contrast. Absolutely. So gastroenterology is not going to be involved in this. I know that we're talking about abdominal pain and that type of thing, but it's usually general surgeons deal with pretty much lower GI tract for the most part. Lower GI tract. So we're not sending this guy home because he's got an 8-centimeter abscess. I said 3, below 3, we would leave alone. 3 and above, potentially percutaneous drainage. Well, I'll let general surgery decide that. We're gonna start him on some antibiotics. Why? Because that dude's got 102 fever. He's got an 8 centimeter abscess. So, I mean, he's febrile as far as I'm concerned. That's likely going away. It'd be nice to have a actual white count, but either way, we know what we need to do with this guy. These folks go home with oral antibiotics. And I don't want to jump on medications because that's going to be your ultimate treatment facility. They'll start on that. All right, we got a few more minutes here, so we can keep going.